Professor Saw, that's beautiful.
Okay.
That's all I need. Now, thank you very much, and welcome again. With me here on stage is Alexandra and Sarim. And maybe, Dr. Ranchod, we would like to give you the opportunity to share a little bit with us the setup at your institution, and when did you first introduce AI? If you could just talk a little bit of that so you bring us all up to speed, that would be great.
Okay, good afternoon to everyone. And again, thank you for the invitation, kind invitation, interesting talks, and good afternoon to my esteemed colleagues as well on the panel. We first purchased the GE AMX 240 in May 2021. And so we've been using the unit at our smallest branch for approximately 3.5 years. And little to our knowledge did we realize, this was retrospectively, that we were the first practice in private to utilize the critical care suite and the unit outside of United States of America. So in Africa, Europe, and Middle East, it turns out that our practice, based on the East Train in South Africa, was the first practice that had the critical care suite. So as you can imagine, it was the first time we introduced AI in our department, and it was a fascinating and interesting roadmap for both the radiologists as well as the technologists in our department, and also for our referring clinicians as to what happened subsequently. We had a short 3-month period of iron out and problems, trying to iron out the workflows and what the discussions were, and teaching our technologists as well as our students as to what to do and how to interpret the AI, and then also what to trigger in terms of calling the radiologists and informing the sisters. So there was a short honeymoon period of 3 months. But we've been using the critical care for a better part of 3 years, and we've had lots of positive stories and lots of instances where patients' lives have been saved. And a few of those stories have been marketed by GE, those case studies that have been marketed by GE regarding actual examples and incidents where the critical care suite was critical in saving a patient's life.
Right.
That's just the background.
Yeah, perfect. Just a quick question. We all know that pneumothorax or collapsed lung can be deadly if not diagnosed correctly. And I think I know papers that it takes up to 12 hours till a radiologist or a doctor actually looks at an image that was done. And we all know if you detect it early, treatment is not so difficult, let's say. And so when you introduce the critical care suite, is it more, or I think we can agree that it's not the question if the AI outperforms the radiologist or the radiologist is still better than the AI. And I'm also looking at Sarim, because you've also introduced it. But I think it's just nice to have a tool that gives you a hint that probably, a patient's images have to be reviewed directly. Is this more the philosophy and approach behind it, especially at 3 o'clock in the morning when the tech does the exam and then can call the radiologist who's probably taking care of a trauma case in the emergency room and say, hey, look, send it with high priority to the PACS, look at it right now?
That's absolutely correct. So the AI will help red flag and triage these difficult cases, and will then also sort of crash the radiologist's list. So it's the radiologist on duty on site in office hours is well and good. He's going to see the x-rays and that. But in a busy department, how do you know whether the first portable mobile x-ray done at 8 o'clock in the morning is more urgent than the one done at just 5 minutes prior, etc.? So the AI definitely red flags and triages those x-rays in high volume departments. But after hours and public holidays becomes more important. And I have practical examples of x-rays being done on a public holiday on Friday. And us being a private institution, everything gets reported. So in an academic facility, most of the x-rays are not reported, just the volume of the imaging that's done, they can't cope. Whereas us in a private facility, none of the cases, if they're not reported, they're not going to get paid or funded. So everything does get reported. But to give you an idea, an x-ray done on Friday afternoon got reported on Monday afternoon. And a pneumothorax on Friday afternoon in a stable patient may not have been picked up until Monday afternoon. And you can argue the reality and the practicality of that. That is a medical legal case. So Saturday, it turns out that the radiologists on duty, of which there were 2, they were absolutely inundated with MRIs and CAT scans and procedures and pigtails and drainages. They were not going to go and tackle that plain film pile. And in this instance, the AI could have red flagged that case and then just said, listen, you don't have to report the 50 other chest x-rays that are there, but this is the one that's important. This is the one where the life is going to be saved. So it does help in after hours. It helps in public holidays. It helps when the radiologists are too busy. And in the day, in the workflow, it just improves the workflow and throughput, and it also augments you at the end of the day. So it does save lives, and we've seen that firsthand.
Thank you very much. I'm looking at Sarim. You also use the critical care suite. Just for the people in the room here, can you just talk a little bit about it? It gives you the percentage, the likelihood that this case is a pneumothorax. Is that right? Is there like a traffic light system?
Yeah. So
and maybe a follow-up question before, when the tech is doing the exam, it gets a quality assurance. Is that right? It checks that the scan was properly performed and does not to be repeated or needs to be repeated. Is that right?
Yeah, that's exactly right. So I think that there's two functions. One is the image quality, and then the other one is the image interpretation. And being able to sort of see how good the X-ray is, it gives the tech the, especially on portable films, having to go back into ICU to repeat the film because the radiologist isn't happy, isn't ideal. So yeah, I think that gives a quality assurance. And then on the interpretation side, with the pneumothorax, you get a continuous probability score from a 0 to 100, and you set your threshold as to where you think in your population you want to call it positive or not.
What is your threshold?
I mean, we just use sort of the default out-of-the-box threshold because that's where all the research has been done. So we feel like, that's where it's been rigorously tested. That's what has been approved on the regulatory point of view. But I think, like you said, in our setting, the value is not necessarily to the radiologist, but to the treating physicians who are going to be looking at those X-rays.
Right. Thank you. You both mentioned that you use it, or at least you mentioned that you use it on your mobile device. How does that work? You get an alert on your mobile device no matter where you are? Is it done automatically? It pops up?
Yeah, so the device has got a screen which gives you the image preview, and within that you get the AI outputs on there as well, so the tech can see before they even send the images to PACS right there and then.
Right. And Dr. Ranchod, the ICU doctors, do they really appreciate this critical care suite? Because my impression is when we introduced it like 4 years ago, it really is a game changer. Everyone I talk to, regarding this, they really love it because that's what they really fear. Even with 30 years of experience in the ICU, it's the pneumothorax they fear.
Absolutely, it was a game changer, and it's a no-brainer to buy a portable unit with a point-of-care solution immediately. As Sarim has said, that you get the instant feedback from the critical care suite as to what the issues on the patient. So ranging from the pneumothorax to the ET tube to the positioning of the patient. So we found quite interesting concepts that have developed, and there's implications financially and with radiation control as well as on rejection analysis. The fact that the unit is able to provide an instant image with an instant assessment, when the patient's been, when the X-ray has been requested, the clinician often waits to see that because he knows it's just a 2-minute story. Once the unit is there, in 2 minutes he has an answer whether the ET tube is fine or the CVP is fine. And then he sees that the ET tube is too deep and he prevents the tech from leaving. He says, no, hang on, I'm going to adjust it. He adjusts it 2 centimeters. He tells the tech, you need to do another exposure. And then he's not correct. He adjusts it a third time and he tells the tech to do another exposure. So we found in the start 2 or 3 exposures were getting done. They had implications there in terms of rejection analysis, radiation control, because we now did 3 exposures. But having said that, it's still overall in the benefit of the patient because while the clinician was there, while the tech was on site, the ET tube was then adjusted twice or beat, and everyone was happy. The tech then left and came to the department and processed the imaging. The surgeon or the physician, etc., were happy, and the patient was stable, and we didn't expect any surprises later in terms of tubes and lines. And we also didn't have the issue, as in the past, where the tech came back to the department, had to go back, and then 2 hours later came back to the department, and they had to go back because it was then done within 5 minutes. So you won't be you'll be surprised that when they order the X-rays, they say make sure the unit with the critical care suite is coming, and not one of the older units are coming to do the X-ray.
Right. Could you share an example where the AI really had a significant impact on patient care or outcomes? I think you mentioned you saved patients' lives. That's what you just said.
Yes. So we have lots and lots of stories, but one of the earliest stories was an incident where a patient received a central venous line. So a CVP line was inserted by the physician, and the physician attempted on the left-hand side and was unsuccessful. He then put in the central venous catheter on the right-hand side. The patient was stable. There was no issues with the blood matrix and the oxygen saturation, etc. So he left the premises and he ordered the chest X-ray. And so he didn't wait to see because the patient was stable. Anyway, the critical care suite, the X-ray was done, and it picked up a very small apical pneumo. And at that point, the patient was stable, and the sister didn't appreciate the apical pneumo, and that was fine. About 3-4 hours later, at about 3:30 on a Sunday afternoon, the patient then developed a tension pneumo. And now he's got a tension pneumo, and albeit he was still stable, but the tension pneumo was a red flag on the critical care suite. And so the radiographer, the technologist, saw that, informed the sister, and then came back hurriedly to the department, processed, and then tried to get hold of the radiologist on call. But as it happens in the odd hours, the radiologist on call had a family emergency and someone passed away at that point in time. So quickly I was then notified to say, please, you need to take over the call, and there's a red flag. And I wasn't at home, so I quickly got home, dialed in, had a look at the X-ray, realized that there's a tension pneumo. Yes, the patient was stable, but it needed an immediate intercostal drain insertion to be done. And so then reported the image, called the physician, and then had a chat clinically about the incident and the patient's status. Spoke to ICU, and then I had to even convey the history to the surgeon. The surgeon was on site in theater, but he was busy doing a case. Fortunately, the patient was stable, so within the hour the surgeon had finished his surgical case, came out, assessed the patient, put in the intercostal drain. Now, superficially, the story is not too dramatic. The critical care suite picked up the pneumo, it was a tension, patient was stable, intercostal drain was inserted. But let's take ourselves back. Let's take ourselves back to the darkroom days, or even to the days where there was no critical care suite and no AI. What would have happened on a Sunday afternoon? The X-rays were done, whether the technologist actually reviewed the imaging, whether the sister looked at the imaging, the patient was stable. And so nothing would have been done. And lo and behold, as usual, 2 o'clock in the morning, the patient would have collapsed. You would have had a resus in the ICU. No one would have been the wiser as to why he's now resusing at 2 o'clock in the morning. And there's no physician surgeon on site but the ER doctor. So the ER doctor would be called as a resus, code blue, and the patient gets resuscitated. But what would have happened? The surgeon is unaware completely as to what happened. The physician may not be aware. I am definitely not aware. And I would then come Monday in office hours, call up the X-rays, try and target the X-rays, triage them. I have no idea. See the tension pneumo when I come across the file. Pick up the phone ICU. Sorry, doctor, the patient resuscitated last night. He passed away.
Right.
That's what would have been the scenario in the past. That's not the scenario anymore. These cases are now red flag in opportune times. Quickly, management is changed, intervention is afforded, and you save lives at the end of the day without much drama. It doesn't get publicized. It's not a big story. But this is how we're using AI to augment our throughput and how to augment and save lives, and also pick up these incidents before they become disasters, before the tension pneumo was going to cause a resuscitation of the patient at 2 o'clock in the morning. This was then picked up Sunday afternoon. Within the hour, the drain was done. The patient is stable.
Thank you very much. We are almost at the top of the hour. I have a final question for you, and this is a financial question nowadays. It's very important. Are there financial or cost-saving benefits to AI? Because this is also very important. On the one hand, it's an investment for a hospital, but on the other hand, you can probably show that in the end, you save money by making an earlier, better diagnosis, time to treatment, and stuff like that. If you just share your opinion on that.
Yeah, I think in terms of timely diagnosis, obviously quicker time to treatment and improving patient outcomes is important. I think the challenge is being able to show that in a systematic fashion. I think for me, the next frontier is actually AI is getting very good at telling you what's normal, because we have a lot more normal examinations than abnormal examinations. So if you can take that normal workload away, then immediately you've got a cost benefit. So I think that's probably the next place we can
That's
go.
every radiologist's dream, but I know it's far from being trivial. What is normal in medicine? But that's another discussion. Dr. Ranchod, I give you the final word here regarding the financial impact of AI and cost-saving potential.
Sure. I'll resonate exactly with what Dr. Sarim and Prof. Su has said. And just it comes down to throughput and cost saving on the basis of throughput and speed of diagnosis. And one other issue is that with the volume of x-rays that are, the repeat rejections that are reduced, so we don't do so many repeat x-rays because of that critical care and the quality suit, we also end up archiving less to the PACS. So prior, you would have had 2 or 3 x-rays going to the PACS, and the first 2 may be non-diagnostic or rotational or movies or etc. And now you discard those images at the point of care, and you then only save and archive. And obviously, there's a cost to PACS and archiving per file or per folder. So I think long-term, it all adds up. Per patient, maybe not, but it adds up long-term.
Thank you. Thank you very much. This was a great final statement. We are at the top of the hour. I'd like to thank you personally, dialing in from Morocco, dialing in from Johannesburg, I guess, and here, of course, Dr. Sarim and Alexandra for a great panel discussion. Thank you very much. Thank you very much.
Thank you.
Thank you. Thank you.